disorder, mental retardation, has a history of seizure disorder, chronic urinary tract infections. She had a previous open distant fundoplication in G2 placement in 2001. She was recently hospitalized with a bowel obstruction, which was thought to be caused by a redundant colon. She was presented with fevers and bowel distension 2 days after discharge from the hospital. I was on call over the weekend, and they called me and placed the central line over in the Jones IMU for her. So I put the central line in, and then we got the X-ray. I noticed that her left side of her chest didn't look right, so I called the medicine doctor that saw her and asked her if I could see the patient as a surgical consult. We got a CT scan at that time, which revealed presence of the stomach in the left chest, consistent with diaphragmatic herniation. She's a little girl, it's Harrington rod, so the images are kind of grainy, but you can appreciate that the stomach is not where it's supposed to be on the left side, and then her abdominal film, which is a good portion of her stomach, above the diaphragm there.
Jason, why is it type 4? You said it was type 4.
It was type 4 because in the operative findings, she had a small piece of transverse colon.
Okay.
The preoperative diagnosis was a type 3 paraesophageal hernia. The final diagnosis was a type 4 paraesophageal hernia. And she has a small, right here you can see she has a small bar-type button that is in the lower hole of her stomach, which was not adequately decompressing her stomach. Also, we had a difficult time trying to place the nasogastric tube. We had the proper length on the tube, but it kept backing up into her mouth despite being able to hear it in her abdomen. So I was concerned for all these things. This is with a picture of a paraesophageal hernia with herniation of the chest. She was transferred to the surgical ICU, and then she began. We had planned for an elective operation on Monday. This was a Friday, and then this was a Friday. She was moved, and planned for an operation on Monday. On Saturday, she had blood from her NG2, and there was concern that she had necrosis of her stomach. She was taken emergently to the operating room, or semi-emergently. She had laparoscopic repair of the paraesophageal hernia. Her distant fundoplication was re-performed, and took down the G2, placed a new G2 of a larger, more appropriate caliber for her body size at this time versus when she was 11 years old.
And your concern was for gastric ischemia. What did you find regarding that hypothesis when you operated?
The stomach was not ischemic. It appeared that there was a slip nissen, as well as enlargement of the esophageal hiatus that allowed the slip. The nissen had slipped, as well as the stomach with the paraesophageal hernia.
Okay.
Excuse me, with the GE junction into the chest.
And so the stomach was viable?
Yes, sir.
Okay.
Yes, sir. And there was a small piece of transverse colon that was there. And in retrospect, we were thinking that maybe that little piece of transverse colon that was there could have caused her bowel obstruction from the previous hospitalization, despite the fact that we did an extensive GI workup at that time. Didn't really feel the obstruction. So.
Jason, how did you decide that the stomach was viable?
And
what part of the stomach dies?
Well, the inside.
Right, so how did you determine that the stomach was viable?
She had an EGD.
Okay, well that is probably an important piece of this, and oftentimes that's the first modality to assess when patients have a paraesophageal hernia and you don't know, and they're not looking quite right, is they need an EGD right away to assess whether or not they have dead stomach. I don't know how many cases we've had in this hospital in my short term here, where that was the first step, and when it wasn't the first step, we got bit by that. If people had more dead stomach than we were able to determine. Can't tell on CAT scan, can't tell on any other imaging. They really, you have to assess
That's right.
their stomach with an EGD when that diagnosis is beginning to be entertained in a sick patient.
And so at the completion of the operation, describe the management of the last part of the operation, the management of the hernia sac. That's the hardest part of this operation for sure.
So the hernia sac was not there for this operation, but the hernia sac, we always try to take it out, but in this situation, the patient was operated on semi-emergently. She was resuscitated in the operating room as well, and resection of the hernia sac via the abdominal approach was not possible at that time. There was from what I understand, there was a good portion of the sac that was able to be resected from the abdominal approach, but not completely. Resected the hernia.
Sorry, I just want to correct you real quick. The entire peritoneal surface of the hernia sac was completely removed.
Okay.
So the abdominal peritoneal part of the hernia sac was completely removed.
Okay. Yes, ma'am. So like I said, I wasn't there for that part of the operation, but,
Well, it's a critical part because you'll find that if you have a paraesophageal hernia, is you just grab it with graspers and pull it down, try to pull it, the EG junction down below the diaphragm. You haven't done anything to the hernia sac, but you got it in a great place, it looks good, let go, whoop, it goes right back up. And that tension there is from that hernia sac. And you got two options. The first option, the best option, is to remove it. But if you don't cut it circumferentially, 360, and release that tissue, you'll always have the tension pulling it up, essentially, back up into the chest. And so you actually won't be able to get your EG junction where it's supposed to be, and you won't get the stomach to stay if you don't attack that. So you have to. But in this case, some portion of the peritoneal surface was that was in the chest was left there because of technical limitations. So tell us what happened.
so she was transferred back to the ICU, remained intubated. She recovered fine, well, initially was extubated, and then a few days later had some respiratory issues, tachypnea, and fevers. We obtained a CT of her chest. And you can see that there's, on the left side of her chest where the hernia sac was, there's a rind, but consistent with empyema, but also there's collapse of this left lower lobe. And so we were thinking that she had either retained hernia sac in her chest, and empyema or hematoma, pneumothorax associated with that, or all the above. So she was taken back to the operating room for a VATS decortication issues, as well as a resection of the hernia sac, and you can see before and after pictures of how much her lung improves.
So much better. Tell us the findings at surgery.
So the findings of surgery were quite impressive. She had a hernia sac for a girl that weighs 40 kilos, about the size. The hernia sac was about the size of my fist, and it was full of had a small hematoma in it. It was a sac that we had to actually open up one of the VATS ports to get out in an endo-catch bag. It was that large. And so the left lower lobe was completely collapsed. When we were withdrawing the camera, you could very nicely see with a good amount of positive pressure that the lung re-expanded beautifully, and she was better. So, but it's a gratifying operation. There was a small rind as well.
And tell us how she's done post-operatively.
She's been difficult to wean from the ventilator. She has, again, severe mental retardation, and we have a difficult time sort of communicating with her, trying to tell her to breathe on her own, and so we're just having a little trouble weaning her from the ventilator. But we removed her chest tube after 3 days after surgery, had to reinsert chest tube for an effusion. It's only about 200 cc's, which doesn't sound like much. You make a lot of pleural fluid, but in a girl this size on the ventilator, it was compromising to her.
So she's still struggling.
Yes, sir.
Okay. Questions?
What's your take on that?
Well, my take-home message is that you always want to try to get the hernia sac out, but I don't think that it was an error in judgment, because at the time the operation was performed, the initial operation, we thought the hernia sac was out. I think that we've actually had 3 patients that have sort of had the same sort of problem in the last month. We're running a special diaphragm hernia, and so we've had to take 3 of those patients. I've had to have a thoracoscopic removal of a portion of the hernia sac, or assistance with removal of hernia sac and decortication. So I'm looking at writing a paper to try to analyze the risk factors that would indicate that you would need a thoracoscopic approach at the same time as surgery to save you a second trip to the operating room. But
why would you not take the sac out at the first go?
So I think that there's some confusion. The sac was removed. The peritoneal surface of the sac was 100% completely removed and put in a bucket. There was no question about complete removal of the peritoneal side of the sac. What she had was the pleural side that remained in its shape because she had had this hernia for a very long time, and the lung was stuck and scarred in the down position and wouldn't re-expand because the pleura was deformed. And so what we had to do is actually remove a huge portion of the pleura that had some hematoma inside it from where we separated the parietal pleura from the hernia sac. So she required a bicavity approach to completely remove both sides. But the peritoneal surface, and we had video, but we didn't have enough time to show it, was completely removed during the first surgery.
So the thing to do is consider putting drains, because what probably happened, even with mediastinal hernia sacs, is that,
That's a great comment. And the cases that we've seen this month, at least 3 cases like this, where they're chronic hernia sacs that have been there for a long time, that are large, I think they need a chest dissection if you've got a big chest component, because the lung is scarred in the collapsed position, and the parietal surface of the pleura makes it not expand, and you're always going to fill that space back up with fluid unless you obliterate it.
Remember, the physics of it is positive pressure in the abdominal side of the diaphragm.
Right, negative pressure in the chest.
And any fluid that can evacuate itself from the chest, I mean, the obey the laws of physics, can go in the chest.
Yeah.
So I've had the medial spinal one where you can't just go corticate your medial spine. I just put in a Jackson Pratt or a 15
Yeah.
blade.
That makes sense.
Run it through my closer and out through one of your 5-minute reports at the end of the case and just put it on suction.
Jason, I have a lot of video. I have a lot of video of you here nodding. So let me ask you a question.
No, I think we're actually out of
Are-
town, so we gotta go. And because we have a visiting professor today from Toronto, who's going to talk about transplantation. I have one quick announcement. Next